Welcome again in your ASCP preparation camp. Today we are going to break diseases of the liver into easy unforgettable points. Let's start. So, when the liver encounters trouble, what exactly are its go-to moves? Well, surprisingly, it doesn't have as many options as you might think. Despite the wide range of things that can harm the liver, viruses, toxins, metabolic stress, its responses tend to fall into just two main categories: acute and chronic injury. Think of acute injury as a sudden, short-term hit. It might be a viral infection or exposure to a toxic substance. Sometimes, it passes almost unnoticed, no symptoms at all. But one of the classic signs, if it does show up, is jaundice, the yellowing of the skin and eyes. Now, chronic injury is a much slower, long-term battle. We often see it in cases of chronic hepatitis, and unfortunately, if left untreated, this can escalate into cirrhosis or even hepatocellular carcinoma, that's liver cancer. So while the early responses might look similar, it's the duration and underlying cause that really shape the outcome. But regardless of whether it's viral, toxic, or autoimmune, what's actually going on inside the liver? The answer lies in one core concept: cell death, specifically, a type called apoptosis. This is a controlled form of cell suicide, where damaged liver cells shut down in a neat, regulated way to prevent further damage. When that happens, enzymes normally locked away inside liver cells leak into the bloodstream. And these leaked enzymes, that's what we're picking up in routine liver function tests. This is particularly characteristic of many forms of hepatitis. Now, here's where it gets clinically useful. Different enzymes tell us different stories about what's going on. Let's break that down. AST and ALT, the aminotransferases, are your main markers of hepatocellular injury. High levels here suggest direct damage to liver cells. ALP, or alkaline phosphatase, tends to rise when there's trouble with bile flow. This points to cholestatic injury, more of a plumbing issue, if you will. And albumin levels is a longer-term indicator. If albumin is low, it suggests chronic liver dysfunction. For acute severity, we look at prothrombin time, PT, or levels of factor V. These reflect how well the liver is functioning as a protein factory, and since clotting factors are proteins, they give us insight into immediate liver function. Alright, let's get into the specifics, the viral players that can seriously affect the liver. We've got the big five: hepatitis A, B, C, D, and E. These are the primary hepatitis viruses, and while they all target the liver, each has its own distinct personality, in how it spreads, whether it becomes chronic, and whether we can prevent it with vaccines. Now, it's important to know that other viruses like CMV, EBV, and HSV can also affect the liver, but they usually do so as part of a wider systemic infection, not as primary liver viruses. And yes, there are mentions of viruses like HGV, but they don't seem to cause significant liver damage, so our main focus stays on HAV through HEV. Let's break them down a bit. Hepatitis A and E are spread mainly through contaminated food and water, that's the fecal-oral route. Prevention focuses on hygiene and clean water. Hepatitis B, C, and D are bloodborne, transmitted through infected blood or bodily fluids. So here, prevention means safe sex, clean injection practices, and screening blood donations. In terms of chronic infection, Hep B and C are notorious for becoming chronic. Hep A and E, in most healthy people, do not cause chronic liver disease, except maybe in immunocompromised individuals. Now here's the game changer: vaccines. We've got effective vaccines for hepatitis A and B, and because Hep D depends on B, protecting against B indirectly protects against D as well. Let's take a closer look at hepatitis A. Historically, HAV was one of the most common causes of acute hepatitis, a major contributor to sudden liver inflammation. But thanks to the vaccine introduced in the mid-1980s, the number of cases in the US has dropped dramatically, to the lowest levels ever recorded. So today, vaccination is recommended for all children, plus adults at higher risk. Who counts as high risk? International travelers. Men who have sex with men. People who use injection drugs. Certain workers exposed to sewage or food handling. And anyone with chronic liver disease, including Hep B or C, because HAV superinfection can be deadly in these patients. In fact, that's a crucial point. While Hep A is often mild in children, it can be much more severe in adults, especially older adults. Outbreaks still happen, often linked to contaminated water or raw shellfish. And here's a stat worth remembering. Infected adults develop jaundice in 50 to 70% of cases. And in those over 60, the mortality rate can reach 2%. In contrast, in children, Hep A infections are often silent, cause little to no jaundice, and are easily mistaken for a mild flu. So while Hep A is generally self-limiting, it can be dangerous for certain populations. Structurally, HAV is a small RNA virus from the picornavirus family. And there's only one serotype, which is great news for vaccine development. One target, one vaccine. And here's something interesting, HAV isn't cytopathic. It doesn't directly kill liver cells. Instead, it's our immune system that does the damage. Immune cells and antibodies attack infected hepatocytes, which leads to the inflammation we recognize as hepatitis. So, how do we diagnose it? Primarily through serologic testing, looking for antibodies in the blood. Anti-HAV IgM means recent infection. This marker typically shows up when symptoms begin and stays positive for 3 to 6 months. Total anti-HAV antibodies mean past infection or immunity, either from a past illness or from vaccination. But here's a catch. Since HAV is now less common, especially in countries with strong vaccination programs, false positives for IgM can happen. So, test results must be interpreted in context, considering symptoms and exposure risk. Let's finish this section with a quick look at the vaccine options. There are 3 main types. Monovalent, protects against HAV alone. Combination HAV plus HBV, 2 birds with 1 shot. Combination HAV plus typhoid, especially useful for travelers. A full vaccination course, usually a shot followed by a booster at 6 to 12 months, provides protection that lasts around 20 years. Now let's move on to hepatitis B, and here, we're talking about a major global health challenge. HBV, the hepatitis B virus, isn't just common, it's the leading cause of both acute and chronic viral hepatitis worldwide. An estimated 350 million people are living with chronic hepatitis B. That's massive. And its distribution? Not even. Rates are significantly higher in Central and Southeast Asia, Central Africa, and parts of Southern Europe, while North America and Western Europe see lower prevalence, thanks in large part to widespread vaccination programs. How does it spread? HBV is spread through infected body fluids. Let's get specific. Needle sharing or parenteral exposure, injection drug use, unsafe medical practices. Unprotected sex. And importantly, vertical transmission, from mother to baby during childbirth, which is a major mode of transmission in high-prevalence areas. Now you might ask, what about blood transfusions? Good news, thanks to rigorous screening, the risk is now less than 1 in 600,000 donations. Inside the virus, the Dane particle. Let's get into the structure of HBV. The complete infectious form is called the Dane particle. Inside, we have HBV DNA, the enzyme DNA polymerase, and the hepatitis B core antigen, HBCAG. This is wrapped in an outer envelope containing the hepatitis B surface antigen, HBsAg, the key marker used for testing. Interestingly, HBsAg isn't just one thing, it has multiple subdeterminants, labeled DYWR, which help classify different strains and genotypes. There are 8 major HBV genotypes, labeled A through H, and they vary by geography. Genotype A is common in North America and Europe. Genotype C dominates in Asia. But it's not just academic. These genotypes influence disease progression and treatment response. For example, Genotype C is associated with higher risk of cirrhosis and liver cancer, and poorer response to interferon therapy. Some genotypes are linked to hepatocellular carcinoma, HCC, at a younger age. HBV mutants, why they matter. Because HBV replicates rapidly, mutations are common. Some of the most important occur in the pre-core or basal core promoter regions, which may suppress production of HBe antigen. So someone could have active viral replication but no detectable HBe antigen in their blood. These mutants are common in high-prevalence areas and associated with higher HCC risk. Other mutations can affect the HBsAg gene itself, especially the determinant, which is the part your immune system targets. This can lead to vaccine escape variants, reinfection. Even false negative results in diagnostic tests if the test fails to detect the altered form of the virus. How does HBV cause liver damage? Surprisingly, the virus itself isn't directly cytopathic, it doesn't kill liver cells on its own. Instead, it's the immune system's response to the infection that causes the damage. Your body sees HBV-infected liver cells as a threat, so it sends immune cells to destroy them. That immune-mediated cell death, via necrosis and apoptosis, leads to inflammation and, over time, fibrosis. So, in essence, the scarring comes from your body's attempt to eliminate the virus, not from the virus doing the killing directly. This immune interaction is key to understanding the phases of chronic hepatitis B. Testing for hepatitis B, a diagnostic maze. There's a wide array of tests, and yes, it can feel like deciphering a secret code. Here's how we make sense of it. Viral antigens. HB's antigen, first-line screening test. Detects current infection. False positives can happen, as in pregnancy. False negatives can occur with mutant strains or in early infection. HBe antigen, historically used as a marker of active viral replication, but HBV DNA levels have largely taken over that role. Antibodies. Anti-HBs, indicates immunity, either from vaccination or past infection. 10 international units per milliliter or higher is considered protective. Anti-HBc, IgM indicates recent or acute infection, or a flare of chronic HBV. Total anti-HBc, stays positive for life after infection, shows past exposure. Anti-HB, used to monitor disease activity and treatment response. Sometimes, results are tricky, like isolated anti-HBc positivity. Could be past infection, a false positive, or even occult HBV. HBV DNA. This is now essential for measuring viral load, deciding when to start treatment, monitoring treatment response. Higher HBV DNA levels equals higher risk of cirrhosis and liver cancer. Occult hepatitis B. Here's a fascinating detail, occult HBV infection. Some people clear HBsAg, but still have low-level HBV DNA in their blood or liver tissue. They often test positive for anti-HBc. This isn't usually a health issue unless the immune system is suppressed. In transplant recipients or patients on chemotherapy, reactivation is possible. That's why HBV screening is crucial before starting immunosuppressive therapy. Now let's turn our attention to hepatitis C, the virus most notorious for its stealthy progression to chronic infection. Hepatitis C virus, or HCV, was only discovered in 1989, but it quickly became recognized as the main culprit behind non-A, non-B hepatitis. Today, it's estimated to affect around 170 million people globally and is a leading cause of chronic viral hepatitis in North America, Europe, and Japan. And the burden has been growing. If left untreated, projections suggest a steep rise in end-stage liver disease from HCV in the coming years. How is it transmitted? HCV is a blood-borne virus, so transmission routes are similar to hepatitis B. Historically, the biggest risks were intravenous therapy drug use, blood transfusions before 1992, when effective screening was introduced. These days, the risk from transfusion is extremely low. In children, it's relatively rare, except in cases of mother-to-child transmission or exposure to infected blood products in certain settings. In some regions, unsafe medical procedures or ritual scarification still play a role. What kind of virus is HCV? Hepatitis C is a single-stranded RNA virus from the flavivirus family. And here's where it gets complicated: its RNA is unstable, leading to frequent mutations during replication. This creates 6 major genotypes, numerous subtypes, and within each person, a swarm of variants called quasi-species. This genetic diversity allows the virus to evade the immune system, establish chronic infection, and fluctuate in activity. The clinical course. Chronic hepatitis C is often a slow burn, but over 20 to 30 years, about 15 to 20% of patients will develop cirrhosis. And once cirrhosis sets in, the risk of liver cancer, HCC, increases to 1.5 to 3% per year. In fact, in many developed countries, HCV is now the #1 cause of HCC. But HCV's effects aren't just limited to the liver. It can also cause extrahepatic conditions, such as cryoglobulinemia, porphyria cutanea tarda, increased risk of B-cell lymphomas, association with type 2 diabetes, prevention and the cure revolution. Preventing HCV has been tough, mainly because the virus mutates too rapidly for a reliable vaccine. But there's good news. Thanks to blood screening and harm reduction strategies, acute infections have dropped by around 80%. And the real game changer is direct-acting antivirals, DAAs, drugs that target specific viral proteins essential for replication. The result? Over 90% cure rates across all genotypes. Yes, that's right, for most people, HCV is now curable. Testing and diagnosis. The first-line test is anti-HCV antibody screening, which detects exposure to the virus. These antibodies usually appear within a few weeks of infection. But false positives can happen, especially with low levels, so confirmatory testing is essential. A recombinant immunoblot assay, REBA, is one option, though now less commonly used. The gold standard for active infection is HCV RNA testing, detecting the virus's genetic material via PCR. One important note. HCV RNA is fragile, so proper specimen handling is critical for accuracy. There's also HCV core antigen, HCV-AG, testing, more stable than RNA and correlates with viral load. It's promising, though not yet widely available in some regions. Genotyping matters. Knowing the HCV genotype helps determine treatment duration, choice of antiviral regimen. Common genotyping methods include serologic assays, direct sequencing, most accurate, line probe assays. Treatment response monitoring. We track treatment success by measuring HCV RNA levels throughout therapy. There are several response categories. On treatment responder, viral load drops during therapy. Non-responder or breakthrough, viral load fails to decline or rebounds during treatment. Relapser, clears virus during treatment, but it returns afterward. The ultimate goal is a sustained virologic response, SVR, no detectable HCV RNA 24 weeks after treatment ends. That's considered a virologic cure, and it dramatically reduces long-term risks, even for those who already have cirrhosis. Alright, let's now move on to hepatitis D, and this one's really unique. Why? Because hepatitis D virus, or HDV, can't survive on its own. It's an incomplete RNA virus, a satellite virus, that requires hepatitis B to replicate. Think of it as a viral hitchhiker. It borrows the outer shell, the surface antigen, HB's antigen, from hepatitis B to assemble itself and become infectious. So here's the key takeaway. You can only get hepatitis D if you already have hepatitis B, or acquire both together. What kind of virus is it? HDV has a single-stranded antisense RNA genome, and it's highly infectious. It's strongly linked to intravenous therapy drug use, and while it's relatively rare, an estimated 10 million people are infected worldwide. Fortunately, HDV incidence is declining, thanks to widespread HBV vaccination. 2 ways you can get hepatitis D. Let's clarify 2 important terms. Co-infection, this means getting HBV and HDV at the same time. Usually resembles a typical acute hepatitis B. If HBV clears, HDV goes away too. But co-infection carries a higher risk of fulminant hepatitis, sudden and severe liver failure, with increased mortality. Superinfection, this is when someone already has chronic hepatitis B, and then acquires HDV later. This is more dangerous. HDV tends to suppress HBV DNA, but ironically, causes more liver damage. Superinfection often leads to chronic HDV and rapid progression to cirrhosis and increased risk of liver cancer, HCC. So bottom line, if a patient has hepatitis B, clinicians should always screen for hepatitis D, especially if liver disease worsens unexpectedly. How do we test for HDV? Testing involves a combination of anti-HDV antibodies, total and IgM, to assess for exposure and recent infection. HDV antigen, though less commonly used. HDV RNA, the most direct way to measure active viral replication. And as for prevention? Since HDV can't exist without HBV, the best protection is simply preventing hepatitis B. That means HBV vaccination. Hepatitis B immune globulin, in select high-risk exposures. By protecting against hepatitis B, we effectively shut the door on hepatitis D as well. Now, let's wrap up our hepatitis deep dive with a closer look at hepatitis E, and a quick note on the elusive hepatitis G. Hepatitis E, while not as infamous as hepatitis B or C, is still a global concern, especially for travelers to tropical or subtropical regions. It's caused by HEV, a small, non-enveloped RNA virus, and a common cause of outbreaks in areas with poor sanitation or contaminated water. But here's the twist. Recent studies have found HEV RNA in city sewage in Europe and North America, and there have been small outbreaks in developed countries too. So yeah, it's more widespread than we thought, and often goes undiagnosed. Transmission. It spreads mainly like hepatitis A, through the fecal-oral route. That means contaminated food or water, especially in places with poor hygiene infrastructure. There are 4 main genotypes of HEV, and we've got serologic tests available now. And here's something fascinating. In the US, studies show surprisingly high antibody levels in the population, meaning many of us may have had silent exposure without even realizing it. Now for the zoonotic twist. HEV has been isolated in animals like pigs and rats, suggesting animal-to-human transmission is possible. Yes, even eating undercooked pork or animal liver has been linked to some human cases. That's a major food safety issue, not just a travel one. Diagnosing hepatitis E. It's similar to Hep A, we rely on detecting IgM antibodies against HEV. But, be cautious, false positives can occur, especially in patients with CMV or EBV hepatitis. So again, clinical context is everything. Now, this is important, pregnant women in late pregnancy, particularly in India, are at much higher risk. Mortality rates in that group can reach 20 to 25%. That's not something we see elsewhere, and we still don't fully understand why. Also, elderly individuals and those with chronic liver disease are at increased risk of complications too. Before we finish, let's touch on hepatitis G, sometimes called HGV or GBVC. This one's more of a scientific curiosity. It's a flavivirus, related to HCV, and it's primarily blood-borne. It was common in blood transfusion recipients before modern screening, and it can be transmitted vertically as well. But here's the thing. Despite high rates of infection, hepatitis G doesn't seem to cause liver damage. You can barely isolate it from liver tissue, even in chronic infection. So why do we care? Well, there's intriguing evidence that in people who are co-infected with HIV, hepatitis G might actually help. Some studies found that those co-infected had lower HIV viral loads and better outcomes. We're not sure how, maybe it stimulates innate immunity in some way. But it's a fascinating area of research. So there you have it, a full tour of the hepatitis alphabet. From A to G, each virus has a different story, different risks, and different diagnostic clues. And for your ASCP prep, understanding these differences isn't just academic, it's essential for clinical decision-making, so don't miss our upcoming episode Acute Hepatitis. And like, share and subscribe. See you, bye.